antigens, T cell development, activation. This, this was one of those things that we needed to sort of focus on. Let me just pull up this picture here because I like this picture here. This is showing one of those important antigen presenting cells that we talked about. We're going to go back through this, but there's a reason I'm going to focus on this picture here because it highlights two very important things. The difference between the way that we can activate a helper T cell and the way that we can activate a cytotoxic T cell. Do both of these types of T cells develop immunocompetence in the thymus?
Yes.
What?
Yes.
Yes, they both develop immunocompetence in the thymus. All T cells develop immunocompetence in the thymus under the control of these thymic hormones. All right? And what this is showing here is that these antigen presenting cells either are going to have class 2 MHC molecules, these fishermen that are going through picking up something. In this case, it's actually picked up a viral antigen that it is engulfed in somehow and presenting to the surface in conjunction with its class 2. Because these types of class 2 MHC molecules, that in this case presenting an antigen, are only found on a very limited distribution of cells. These class 2 are only going to be found on antigen presenting cells, the dendritic cells and the macrophages, and lymphocytes, because lymphocytes are going to need this for full activation as well. But because it is a cell that also has a nucleus, like virtually every other cell in your body, these dendritic cells and A&P2s also have the class 1 MHC molecules. Now, what other cells have these class 1 MHC molecules on their surface to present antigens? All cells that have a nucleus. Would skin cells have this even?
Yes.
Yes, except for the dead surface ones. I'm not talking about the dead surface ones. Can the dead cells do anything?
No.
Why not? Because they're dead. Okay, good. We've gotten through that complex issue here. But the living ones down the lower layers, epithelial cells, for example, on your respiratory tract especially, they're going to have these MHC1s on them here. And the big issue is that they have to dock up with different types of docking stations that would be found on the surface of the T cells. CD4 complexes are only going to be found on helper T cells. And they have to match up with the class 2 MHC molecules that are presenting the antigens. Whereas for the class 1 MHCs here, they have to dock up with a CD8 complex that's only going to be found on what kind of cells? Well, for our purposes, it's going to be the cytotoxic. The T with a little subset C stands for which ones? The cytotoxic T cells. So, quick question. Can dendritic cells potentially activate both helper T cells and cytotoxic T cells?
Yes.
Can they do both? Can dendritic cells? Yeah, let me do that one. How about monocytes? Can they do both?
Yes.
Monocyte macrophages?
Yes.
Yeah, because they're also antigen presenting cells. Could epithelial cells activate both?
Yes. No. Yes. No. Yes.
Could epithelial cells activate both? No.
No.
Which one would they be able to activate? Only the cytotoxic ones. What about a infected muscle cell? Which one could they activate?
Cytotoxic.
Just the cytotoxic. What about a fibroblast in connective tissues?
Same thing, cytotoxic.
Yeah. Okay, now you're getting the picture. I just want you to understand that virtually every cell can potentially activate a cytotoxic T cell. Potentially activated cytotoxic T cell. All right. But I am focusing on these antigen-presenting cells because, first of all, they can do both. They can do both the cytotoxic T cells as well as the helper T cells. And on top of that, they just do a better job of both of them, even for the cytotoxic T cells. They're just more effective at presenting them and chewing them up and presenting them than other cells in your body happen to be. They specialize in doing this. The other cells can do it, but they don't really specialize in presenting for cytotoxic T cell activation, but they can do it. So we talked about how both MHC1s and MHC2s, just highlight these. Both MHC class 1s and MHC2 class 2 are these fisherman proteins that have a little groove on them, excuse me. I can go down, but I can't go up there. Have a little groove on it where they can display an antigen that they picked up. It doesn't have to be an antigen. This is whatever they happen to pick up. So I'm not going to go into the differences between how the MHC1s and the 2s do it. Some have to go through phagocytic vesicles. Don't care that you know about that difference between them. What you should know about them is that they're picking up something that they find from the cell's interior. That little groove, they're going to pick up something and display it on the surface. If what they pick up and they display on the surface is something that a normal healthy cell would have, it's letting the white blood cells that come by let you know, okay, this is a healthy cell, nothing foreign here. They're gonna check it out anyways to make sure it isn't something that's foreign, but then they'll let it go by. But if this is a cell that's been infected and it's picked up a little bit of a viral or a bacterial protein and now it's displaying it, well now a lymphocyte that also recognizes the same antigen potentially could be activated by that. All right. The reason I bring this up, somebody mentioned it, because we're talking about how the T cells have to be activated by something that was inside a cell, presented to the cell. And I had some students who were like, well, it's showing it on the outside. It's showing it on the outside, but I thought you said that the antigen had to be presented from the inside. Well, it's just an artist's representation. Was this little cone thing at one point inside the cell? Yeah, that's what they're trying to show here. Here's the deadly cone virus fragments here that have been picked up. I'm really scared of this one here. The deadly cone virus that was inside the cell, now being presented by this MHC class. In this case here, it's probably a class 2.
So those are the steps to, like, because I'm reading.
Right, these are the steps that you do not need to know. You're welcome to learn them because I don't want to stop your educational processes here. But the key thing I want you to know, the only thing I'll test you on is what kind of cells have MHC1s and what kind of cells have MHC2s. You better know that. You better know that they also pick up antigen fragments from the cell's interior. And I'm not going to ask you about the process of how that goes on. Unless you want me to ask you a question about that. I would do that for you, because I'm the professor who cares. But for everybody else, I just want you to know that they are picking up antigens that they have picked up from inside the cell. And the third thing you need to know about them is what kind of lymphocytes they have the ability to activate. If something picks up something in a class 2, what potentially could it activate? What kind of lymphocyte can be activated? Something that has a CD4. Didn't I do the stupid math trick last time?
Both have to equal 8.
They both have to equal 8. Stupid math trick. 1 times 8 is 8. 2 times 4 is?
8. As long as they both equal 8.
As long as they equal 8. So the 2s, MHC2s, have to dock up with this cell that has what? The CD4. And what cells have the CD4s? The helper T cells. You better know that one. CD4s found where? Helper T cells. What do helper T cells have? CD4s. What do helper T cells have? CD4s. What do cytotoxic T cells have? CD8s. What cells have CD8s? Cytotoxic. Which cells have CD4s? Helper T cells. Which cells have MHC class 1 presentation, antigen presentation complexes? Which ones have MHC class 1s?
Cytotoxic.
Which ones have MHC, well, no, first, which cells have the MHC class 1s? All cells that have a nucleus. Which cells have MHC2 antigen presentation complexes? Which cells have the MHC2s? Only the lymphocytes and antigen presenting cells. They have the MHC2s. And if an antigen is presented in conjunction with the MHC2s, it could activate what kind of cell? Helper T cell, cytotoxic T cell, B cell? I'll just throw in some other things for you here.
Cells.
Hmm?
Oh, that's hyper T cells.
You were saying what?
Hyper T cells.
Right. Enough of that. All right, we talk about how the bees develop their immunocompetence in bone marrow. The 3 R's, I think we finished with the 3 R's last time, didn't we?
Yeah.
I mean, this is kind of where we sort of finished, right? Is that in order for both cellular and humoral immunity, and by the way, when I talk about both cellular and humoral immunity, of these two types, cellular or humoral, which one is provided for by B lymphocytes? Humoral. Humoral because it's bodily fluids, and the antibodies they create are found in every fluid you produce, except for urine. That's not really the same, but every other fluid that does that. Cellular immunity,
T cells.
the T cells, because they're the only ones that have potential for direct cellular attacking, the cytotoxic T cells. Now, for full immunity, they have to recognize its specific antigen. Co-stimulation is necessary for the T cell activation. Again, you have to have the MHC1s with the right 8s and the 2s with the 4s. This occurs as physical interaction between the MHCs and the cluster of differentiation, as the CD4, CD8s, and or by sort of the cytokines. These are the interleukins. Interleukin 1, interleukin 2 are the main ones here. They have to react. It involves clonal expansion, which means that once you get the right stimulation with the helper T cell, we start to divide into massive numbers of clones. Are all the clones going to be genetically identical to the original activated one?
Yes.
Will they all be able to fight against the same antigen?
Yes.
Is that the whole purpose of doing this?
Yep.
Yeah.
Absolutely. And then the third one down here is the remembering part. is that not all the cells that are formed in the initial activation will be involved in the initial fight. Some are going to hang back and become memory cells that will provide immunity down the road if you ever get exposed to the same thing. And so we're seeing what we've seen before, the T cell activation, where the dendritic cell, in this case here, is displaying their little antigen fragments on their MHC1s and on their MHC2s, all right? And the MH1s and the 2s, in this case here, are going to be binding to their, naive helper Ts and cytotoxic T cells, all right? They're naive because they've never been exposed to their antigen before. Are they immunocompetent? Yeah, immunocompetent so they can recognize it. Naive because they've never been exposed to it before here. So they bind to these co-stimulators here. They match up correctly here. And once that occurs, then we have this clonal expansion here. They start to divide rapidly over a period of time. Most of them become effectors. A few of them hang back to become memory cells. Only thing that's mentioning here about the interleukin-2, notice that it says that the cytotoxic requires activation from one T sub H. What does that stand for? Helper T cell. So the bottom line is that for full activation, whether it's a B cell or a cytotoxic T cell, you're going to need input activation by the helper T cell. All of them require that. And this is sort of showing the interleukins that they are the activated helper T cell being activated here by a macrophage here, probably an MHC class 2. Don't worry about all what the interleukins are doing. Interleukins, as the name implies, are chemicals that are used to communicate between white blood cells to activate different parts of the immune system here. And it's just sort of showing it stimulates B cell proliferation. Interleukin-2 activates cytotoxic T cells here. Interleukin-3 actually is involved in a lot of innate immunity stimulation here. So, cytotoxic T cells. Well, what do cytotoxic T cells do? They are the only ones that can kill. And their killing mechanism is primarily by lysis. They secrete chemicals like perforin. Did I use that term in here before? I thought I have, but I want to make sure. It's a great name. A great name because it's going to perforate, poke holes in the target cell membrane, causing it to explode here. There are other enzymes that it can release inside that will cause the target cell's DNA to basically get chopped up like in a blender. And that's also a good way to kill a cell, is you destroy its information that allows it to make new cells here. So the combination of destroying the DNA, destroying the chromosomes basically, and poking holes in it, it's a very effective killing mechanism. B cell activation. First, notice they're probably showing a lymph node, common place for it to come across its first activation here. Does a B cell need to have its antigen presented to it?
No.
No, it doesn't. So is that a nice thing? Because now we don't have to worry about all that crap about MHC1s and MHC2s and CD4s and CD8s. Do we have to worry about any of that shit now? No, because we're talking about what kind of cells? B cells. They can be activated by just a free-floating antigen, at least initially activated. Will they still need input from helper T cells?
Yes.
Yeah, so they're showing a helper T cell here that after activation have to stimulate it with cytokines, interleukin-1, interleukin-2. Once the T cell has activated it, then that cell begins to divide into an army of activated B cells, most of which mature into these bloated plasma cells. They're nothing but antibody factories. What else do plasma cells do? Nothing I know of. They make what? Antibodies. Antibodies, antibodies, antibodies. And then some of them, of course, are going to remain up as memory cells that will be involved in secondary fights. And we did do this also too last time, didn't we?
Mm-hmm.
Yeah, okay, so we did do this. So it's been a long week, hasn't it, people? Right?
Yeah.
We pretty much forgot everything, didn't we?
It feels so
Yeah,
long.
just wipe that slate clean, right? It just falls out, just falls out. Just shake it, it's all that information.
I think variable regions, you said determine the antigens, I can't say that word,
Specificity.
And then you said the constant regions determines the constant class.
Absolutely. And I gave you a little example over here, right? Two different sort of two different type of lymphocytes that were activated. All right, good. Close your eyes, everybody. Between all the different close your eyes. Between IgA, IgG, IgM, those are the big three there. IgA, IgG, IgM. Which of those three can cross the placenta?
IgA.
Exactly, IgG, you were all correct. IgG is the only one that can cross the placenta. Which of them are going to be found in secretions?
IgA.
Again, you were all correct. IgA is the only one that's found in secretions. Would you find IgA in tears,
Yes.
mucus,
Yes.
in milk?
Yes.
All of those secretions would contain IgA.
Right.
IgM is the biggest one. IgM is the first one that's produced in a primary response. It's this massively huge one here. And so that's the kind of test question usually with IgM. It's the first one that's released in a primary response. So during a primary response, once that B cell has undergone its full activation thing, the first thing it will start to spit out is IgM. After a day or two, it will start to turn over and start to produce more IgG until a couple of days later, IgG is far and away the most prevalent that's going to be found in a primary response. It's just not the first. It's also something that we mentioned before. It's also the type of antibody produced in response to foreign ABO blood types. Can it cross the placenta?
No.
No. Is this why it's safe for a mother who's got type A blood to be carrying a baby that's got type B blood?
Yeah.
Yeah. Because there's never going to be an issue with this crossing the placenta. And IgE was the last one. Did I tell you what E stands for?
No.
Evil. IgE stands for? Why do I say evil? Because it's involved in evil things, allergic responses. They bind to mast cells, triggering inflammation because of this. So when you have, for example, anaphylactic shock, don't you hate when that happens? Don't you hate when you almost die from eating that peanut that somebody slipped into your food? That you hear horror stories. Have other people heard horror stories of people, other family members don't believe, that my sister-in-law, she's just making that shit up, that she can't eat peanuts. And they'll slip that into their food. You've heard these stories? You know people? Just to actually see, okay, I think she's just lying, right? Until her sister-in-law blows up like a balloon and almost has a heart attack. Oh, I guess she really was allergic to peanuts after all here. But things that people will do. In any case, so IgE is what, people?
Evil.
Evil. Allergic responses. All right. What I was just mentioning was anaphylactic shock, those kind of hyper, inflammatory conditions here. IgD, don't even worry about it. I'll never test you on that. IgD is actually what the receptor on a B cell looks like here, which is why, if you notice, when they try to draw like B cell receptors, like B cell receptors. This is actually technically an antibody. It's an IgD antibody. Does anybody care? Because I don't. Do I care about the others? Oh yeah, I care about the others because they have clinical significance. IG, and nobody cares. Not me. Probably somebody out there, somebody's mother cares. How can I save time? No, I won't do this complex here. Okay. So this is a big one here. Mechanisms of antibody action. How do antibodies protect you when I've mentioned multiple times that they cannot kill? They cannot kill. Let's take a look at some of the things that we've actually already covered in here already. One thing that we've already seen that antibodies can do is to fix complement activation. Remember, complement was a series of proteins that could be inserted into a target cell's membrane, cause them to explode, death by lysis. And the most common way, in the classical pathway, complement, C3 is that magic piece. C3 gets fixed by antibodies that have been previously attached to the cell's membrane. And this is a critical way that antibodies can help to kill bacteria and other things that are made up of cells. Is this going to work on viruses? No, because they're not made up of cells. Something else, though, that might still work here, opsonization. Opsonization means that when antibodies are attached to something, it triggers the phagocytes to come and eat them, destroy them. And all the other phagocytic cells, neutrophils, macrophages, even on occasion, a basophil can do it, even an eosinophil can do it, but it's really primarily the macrophages, monocyte macrophage line, and the neutrophils that really take advantage of this. And this opsonization, not only is this good against bacteria, but opsonization also works against viruses. Because you can eat a virus, then hopefully you can destroy it by digesting it on the inside here. So we have that action in here. Now, neutralization. Neutralization, a critical one, because pathogens are generally have to have something on their surface that's either going to interact with your surface things or affect your bodily cells. And if we can cover these cells, or if we can cover these antigens, whatever they happen to be, a virus or a bacteria, or whether it happens to be, for example, a little toxin, for example. If we can cover it with a coating of antibodies, if you will, then that's going to prevent it from getting to the receptors that would allow it to have access to a cell. Or if it's a toxin, for it to interact with the neurotransmitter that it is duplicating or whatever like this. And so neutralization is very effective against viruses, because again, when you cover with the viruses with these antibodies, they're no longer going to be able to infect cells, right? They're still, potentially they're lethal, right? But they're not going to be able to have access to the cells that they would need in order to reproduce and kill you. So neutralization, very effective against viruses, very effective against toxins. Remember I was talking about passive immunity in one of our last classes, and about how one type of passive immunity occurs when you take an anti-venom serum. Mm-hmm. Anti-venom serums, the antibodies in those anti-venom serums primarily function this way, because you get that big bolus of antibodies that were produced against rattlesnake venom. Was that the snake that I think?
Yeah.
Or do we do cobra or whatever we did?
It was a poisonous snake.
It was, right. And it will cover them and prevent those toxins from having their effect on them. So neutralization, very important. Something that can go along with this is agglutination and precipitation. Agglutination and precipitation just means they're going to cause things to clump together. It's like herding kittens. Keeps them from getting out, keeps them from doing more harm as we sort of clump them together, herd them together. Also makes it much easier for the phagocytic cells then to do their job once we have gotten a bunch of them sort of clumped into place. IgM, because it has 5 little stars to it, IgM really specializes in agglutination and precipitation. And of course, this is why if you have a blood transfusion of the wrong type, you get that agglutination, that clumping together, because it's the IgM that's doing that job. Now, it also, IgE can also do what? Stimulate inflammation. Remember, IgE is evil. But keep in mind, a little inflammation is good. A little inflammation is required to lead to the healing process. So in the back of your mind someplace, when you hear that term, inflammation, 2 things should come in your mind. First of all, you should be asking yourself, are we talking about an acute inflammation or a chronic inflammation? Because there's different mediators that do those different things, all right? And as a rule, for most conditions, it's chronic inflammation. Somebody has tendonitis or bursitis or some sort of chronic condition like that that's going on all the time. That's a different set of mediators. Short-term inflammation can usually be good, lead to healing, unless it's like inflammation of your airways, for example. You can't breathe. That's a bad thing, all right? Or other types of inflammation that would cause, for example, your brain to swell. Hey, when that happens too. Okay. Immunologic memory in response to antigen exposure. Let's take a look at this. This is a great little chart. This is sort of showing the difference between a primary immune system response and secondary immune system responses. Notice in a primary immune system response, the first type of antibody that's released is what class? IgM. First one in this class. Then later IgG takes over again. But the key thing to know about this primary response is it's relatively blunted compared to these secondary responses. That it takes a good 4 to 5 days before you really even start to develop anything in it here. It peaks in takes about 14 days till you really start to see a peak, all right? And the duration of it's relatively short, about 3 weeks out, that's about it, all right? But secondary responses, lag days can be a couple of days depending on what, but in many cases, the secondary response begins even within hours. And notice that when the antibodies peak within a couple of days, 3 to 5 days, you start to see a peak of antibodies. And it doesn't show that on the chart here because they're showing the complement or the concentration, but what they're not showing is that this is an exponential scale. So it looks like here, okay, looks like the IgG levels looks like it's double, right?
Yeah.
Looks like it's about double like that, but this is an exponential scale.
Do the memory cells help with that immune response?
Oh, the secondary responses are all about the memory cells. Secondary responses are all about which cells? Memory cells. It's the memory cells that will then start to undergo rapid division. And will all the memory cells in the secondary responses be involved in the next fight? Or will some of those memory cells produce another group of memory cells? There's another group of memory cells.
I got a quick question. You said IgM response, if someone take like a blood transfusion, but I know like a nurse will stay with them for the first 15 minutes.
I'm sorry, what?
You said that for IgM, that the lag phase, 4 to 5 days, but then you also mentioned it with blood transfusion. And I know like if someone gets a blood.
Oh, that's a whole separate
it's
issue.
different. Oh, okay.
Not apples and oranges.
All right.
We're talking about it takes that long for you to develop a primary immune system response.
Okay.
In blood transfusion, those antibodies are already there and present here.
All right.
They've been produced, they start to get produced early on, whether or not you've ever been exposed to it. So it might look like it's double or triple, but it's actually 100 to 1,000 times stronger. That's the level of antibody difference. Again, it's an exponential scale. They're leaving that out. Again, 100 to 1,000, write this crap down, people. 100 to 1,000 times more antibodies in secondaries. And you get the numbers within hours, they start going up. Within a couple of days, they're peaking to 1,000. Those absolute numbers that I just gave you, like hundreds to thousands, not nearly as critical as just understanding the magnitude of difference. That secondary responses are not equal to primary responses in strength, not a little bit stronger, not like 2 times stronger, but massively stronger. That's where that 100 to 1,000, sometimes it could even be more than that. Which is why you generally do not get sick from these secondary exposures, even though you are technically sick with it, all right? The viruses or bacteria don't generally have time to reproduce enough to cause any kind of symptoms. So most people during secondary immune system responses are asymptomatic. They might still have some of the virus or bacteria, if it's like a strep throat, they might still have some of them, but not enough to cause that patient generally to be symptomatic. Where if they are symptomatic, it is at a way, way reduced level than you would get in a primary response. And notice the duration of the response lasts 28 days and belongs. So once you develop the secondary responses, it doesn't just shut off after a couple of days here, after a couple of weeks. It keeps going for months even afterwards here. Much stronger secondary responses. So, to refresh of something that we've mentioned before about immunity, active versus passive immunity. In active immunity, do you develop your own memory cells? That's the hallmark of active immunity, is that you develop your own memory cells because you have been exposed to an antigen. And they've gone through all of those steps that we've talked about in order to get full activation to develop memory cells. It is the memory cells that will provide protection. Naturally acquired versus artificially acquired. Which of those would you prefer?
Artificially?
Natural, for example, means that to develop immunity to polio, you have to come down with polio. That would be the natural way of doing it. Artificial means, nah, we're not going to actually get you sick with this. We're just going to give you dead portions or the proteins on the spike capsules or something like this to provoke your own immune system to develop memory cells. But what they give you should not actually make you sick, all right? Now, this is going to maybe sound a little weird here. Now I've got a minute or two here. When you get sick with something, a lot of the symptoms, and in many cases, the thing that cause death, are not the pathogens themselves. What often kills you is your body's attempt to rid itself of these pathogens. So because, for example, if you come down with something like diphtheria or cholera or something, right? Something through your digestion, your body's going to try to get rid of it. The only way it knows how to try to do what? Flush it out both sides, all right? All right? And if you're flushing everything out down there, are you going to dehydrate?
Yes.
Are you going to have electrolyte imbalances because of that, all right? And so I know this might sound a little strange, but diarrhea is one of the leading causes of death worldwide because of the electrolyte imbalance because of the dehydration that goes along with that. So a lot of diseases like cholera, diphtheria, even flu, for example, like this, if it doesn't kill you, can certainly weaken you tremendously. So a lot of the symptoms that you get, like the coughing and stuff like this that goes along with a lot of things like this, is basically your body's attempt to rid itself any way it can. It doesn't know that its attempt is going to kill you. It just doesn't know that. It's just your body. Now, having sort of said that when you are producing a primary response, are you still releasing cytokines? Is that going to cause you to release interleukin 1 and interleukin 2s and all the things during that co-stimulation, right? Are a lot of those things potentially can make you sick? Yeah. So a lot of people who have a vaccination will have some type of mild reaction to that because your body is thinking, okay, there's something here, I'm going to develop an immune system response, start to release interleukin 1, interleukin 2, other cytokines here. And so some people who get a vaccination are going to see those kind of symptoms afterwards, maybe get a fever, or certainly injection site soreness, as almost everybody is going to get that. But you shouldn't be surprised when people get some mild level of discomfort or sickness, a little fever or something, chills or something like that after a vaccination, all right? Because your body is still trying to mount a primary immune system response. Artificially acquired still, that's my preference. Well, I'd rather get the vaccination than get polio. That's just me. Doesn't have to be you. Passive immunity means that you are protected by antibodies that you did not produce yourself.
Like a mother.
Like a what?
Like a mother and her fetus.
Like a mother and fetus. Class example. What class of antibodies, if we're talking mother to fetus or mother to child, there's only one class of antibodies that's involved in the mother to fetus and another one that's involved in mother to child. Mother to fetus, IgG. Yes, that's IgG because IgG is the only one that can do what? Cross the placenta. But what class of antibodies would be found in mother's milk to confer some passive immunity? IgA. IgA would be for that one. So passive immunity, naturally acquired from like mothers to artificially acquired, as we mentioned, like to make an anti-venom using some sort of lab animal to develop them here. Which of these two types of memory, active or passive, are going to be longer lasting? Active. How long does passive immunity last? A couple weeks, really. A couple weeks, maybe a little bit longer, because the antibodies are proteins that have a half-life like everything else. They're going to break down over time. So passive immunity, relatively short-lived.
And a quick question.
Yeah.
Why are vaccines considered active immunity and not passive if they are both artificially, like passive can be artificially acquired and so can active be artificially acquired?
It's considered to be artificially acquired active because the vaccination is triggering you to produce memory cells. In this passive immunity here, there are never memory cells that are produced because you're not fully activating an immune system response. You're only getting the antibodies, you're not getting the antigen that's causing the problem. If you get an antigen, either live or functional or non-functional, you develop active immunity. If you do not get this, just pure antibodies from mom or from some anti-venom lab, you're not going to develop memory cells. You're just going to get what protection those antibodies have given you. That's your passive, that's passive immunity, whether it's natural or artificial. Question?
Kind of. So if a mom gets COVID vaccine, right, and she's pregnant and then she gives birth, the baby has the antibody for COVID?
Yes.
But then you said it only lasts for a few weeks.
Yes.
So technically the baby doesn't have it.
No.
Oh.
No. But at least while that baby if that baby continues to breastfeed from mom, then there will be some protection, at least of the baby's upper respiratory digestive, because that's where all the IgA that the baby is drinking ends up, coating the digestive tract. So it's not going to have a huge impact on the baby's COVID-19, because that's a virus that's going to be basically bypassing digestive, going into the respiratory system. And so very little of the IgA that is found in mother's milk is going to make its way into the baby's respiratory tract. You don't want the baby sort of be aspirating milk. Babies hate when that happens. Mothers hate when that happens too. Everybody hates when that happens. So for a few weeks though, at least, there will be some immunity, some passive immunity to that. So the other issues about how soon can you vaccinate babies, that's the other sort of issue about that. You know, what's the earliest, and for doing that, you just have to look at the data for, you know, at the CDC or other organizations who chart that kind of thing. And right now, I don't think they're recommending vaccinations for babies under 5 even, I think. Nothing for that. I think over 5, I think.
I think it's 5 and up.
5 and up.
Are we gonna get tested on this, the response to cold and the other
No.
bacteria infection and stuff?
No, the response to a cold is just to highlight how this all fits together in the course of an infection. So for example, this poor individual here has breathed in some cold viruses. So this poor individual has breathed in some cold viruses here, all right? The viruses are going to be then infecting, I hate when that happens, infecting cells here. Here's the virus of the infecting cells, causing lysis. Notice that it's sort of showing here is that you will always begin with these innate responses, all right? Because it takes a while for the true immune system response to kick in. So you'll start to produce interferons, right? Because interferons are one of these non-specific mechanisms that prevent viral replication, so to slow down viral replication, all right? If this cell here if this cells are epithelial cells, could they themselves, if they're infected, could they activate different types of T cells? Could they? What type of T cell could it activate? And not the NK, because those are natural killer cells, that's completely out of pitch. Which type of T cell? If it's an epithelial, it could do, oh yeah, cytotoxic, right?
Yes.
It by itself could begin to activate as cytotoxic, right? Because all cells have the CD, or the MHC class 1s, correct? So if these are epithelial cells, would they have MHC class 1s? Could they themselves activate as cytotoxic? Yes. But the compounds get into the bloodstream here. Now we can get a dendritic cell that can take a naive helper T cell to activate it. This is sort of showing how we have to have that double docking station. That's the only thing I want you to get out of this thing here. The double docking station will fully activate a naive B cell here, and it will start producing antibodies. As a plasma cell, well, why aren't they showing memory cells here? Will some of these cells become memory cells?
The ones that stay behind you.
The ones that stay behind? Yeah, I don't know why they're not showing that here, but yeah. Some will stay behind, become memory cells. But the rest of them here are becoming plasma cells, producing antibodies that are surrounding it. It looks like we're neutralizing it, aren't we? We're covering with antibodies, so these little viruses here are no longer going to be able to infect other sort of cells here. And here we have an activated helper T cell that's activating the cytotoxic ones. The cytotoxic ones are now killing the infected cells, preventing them from spreading their disease. It's just showing a slightly different thing with bacteria, because for bacteria infections, as opposed to virus, do we have other mechanisms that are good against bacteria?
Yes.
Neutrophils come into play here, right? Neutrophils come into play. Are we going to get interferons with this type of bacterial infection? Interferons?
No.
Interferons only for what? Viral infection. So instead of using interferons, instead we're going to use things like complement, right? Because complement are good for helping to kill bacteria. But the rest of it looks the same. We take our naive cells, activate them to become activated cells, activating plasma cells, macrophages here. Let me get that smaller. I think that's, if you're interested, which you all are not, so let's just pass that. The things on here. That concludes the information that I'm presenting that you will show up on the test. There's other stuff on here, to save time, I'm going to skip all this here. It's just talking about aging effects, exercise effects, how antibiotics work. I will mention, only thing I'm going to mention quickly about antibiotics, and not about gram-positive, gram-negative, because you're all going to have to take courses in microbiology, usually at gunpoint,
Oh my God.
to take that. And you'll learn about gram. Are you taking it now, or have you taken that before? Most people, when you talk microbiology, all of a sudden, no, I don't want to talk about that. Gram-positive, gram-negative. But what I do want you to sort of be aware of right now, is that many people are right now, is the idea of natural selection. What I'm talking about, natural selection. Natural selection means that it's sort of you sort of think about natural selection as the survival of the fittest, survival of the strongest. People sort of heard this before. When you treat individuals with antibiotics, or even somebody who has a full-blown infection, you're treating them with maybe antivirals, you are exposing that individual to powerful agents of natural selection. Which means that if that individual, let's say if some individual begins, let's just do this. Here's an individual, that's not great. All right, so this is my drawing skills here, okay. That's my person there. Let's make this a prehistoric group. This is a caveman. All right. Give me a name for this caveman or woman.
Robert.
What? Robert?
I heard Roger.
That's a real caveman-y name. Yeah, Robert. Okay.
Bobo.
Bob. Okay.
Bob. I like that.
Bruno.
So Bob's a caveman. All right. I was gonna go for some like Ugh or some kind of name, but you know what? Bob is okay.
Why you just call him COVID?
Because Bob, well, let's give Bob a bacterial infection. Let's give him her. So Bob's going to come down with a bacterial infection, all right, from his tribe, all right, bad bacterial infection, all right. And it turns out generally one is not going to. You need to have a certain number in order for it to really be a full-blown infection. But for ease of use, we'll just say we started with one, just one bacteria. One bacteria. Is one bacteria by itself going to cause anybody any kind of problem? No. But if he gets purchased inside of here, the right place, 20 minutes later, he'll multiply to become 2. 20 minutes later, 4, 8, 16,
20.
until like a week later, now we have like millions of copies of this original bacteria, all right? Will there probably be some, if there's a million, maybe a billion, maybe not that many, will there probably be some mutations in this? Let's say that it develops One of them is resistant to penicillin. One of them. Everybody with me on that? Million, one of them is resistant to penicillin. All right? Is this one that's resistant to penicillin, is it going to have an advantage over all these other bacteria in Bob?
Yes.
Can you explain why?
Because
It won't die from penicillin.
It won't die.
It'll develop.
Why won't it die?
because it's resistant.
Because it's resistant to what?
Penicillin.
So let's back up a little bit. Who was Bob again?
Caveman.
A caveman? How far back in time were we going?
Billions of
So
years
there's
ago.
no moldy bread anywhere?
There's no moldy bread anywhere. Are we treating people with penicillin back then?
No.
No. Is this resistant one going to have any benefit at all
No.
over the other ones? In fact, most mutants tend to be weaker in other areas when they develop resistance, right? So two things potentially going to happen with Bob, all right? One thing that could happen is that Bob might start to, in an infection, he could start to spread these bacteria, right? Maybe if it's a strep or something, he could be coughing, he could be spreading this, maybe through waste materials like this. Everybody with me?
Yeah.
So he could be spreading this infection to the other members of his tribe. What are the odds, by the way, what are the odds that the ones that he is going to be spreading are going to be the resistant ones? Would you say the odds are very high or very low? Extremely low. The ones he's probably going to be passing are which ones? Just the regular ones, right? And passing them, right? And then what's going to happen to this one resistant one? End of story, end of the line. Or, all right, Bob's immune system could eventually fight it off, get stronger, fight it off. He could survive this infection, in which case all these would also be what?
Die.
They're all going to die off, right? End of story. Let's jump another couple tens of thousands of years into the future to, let's say, this is future gal. This is future gal. That's the way I do dresses when I was 5 years old. I'll put a little flower. Oh, a little flower there. That's my limits of my drawing skill. I was sick for a week in second grade when we worked on drawing, and I never really caught up. So, which is why I've kind of stagnated at this level here of drawing. Don't judge me, people. This is future gal, who's living, not now, but 20 minutes into the future. What's her name?
Olivia.
Olivia?
Yeah.
This is Olivia. The reason I'm picking Olivia out of this entire population of future people is that she too has come down with the same infection. She started with how many? One bacteria.
And
All right, she's fine, but a week later, oh my gosh, she is really sick because now she has what?
a million.
1 million. And just like poor old Bob here, one of his or one of hers also happens to be resistant. One is resistant. One of them is resistant to penicillin. Great. So a week later or so, she's feeling really sick, all right? And because she is a filthy, rich woman, she gets to go to a doctor because she lives in this country, which is what it takes. She has everything. Oh, can I afford the deductible? Can I go someplace here? Do I have to go to a free clinic, all right? I'm bringing up all my issues with healthcare in this country here. I shouldn't be burdening you all with this here, but I can't stop myself from doing that here. But she's going to go to the doctor, right? Oh, I'm sick. I've got this bacterial infection. And guess what her doctor, in this case, is going to prescribe? Penicillin. So the doctor prescribes penicillin, all right? And guess what penicillin is going to do? It's going to kill off which ones?
Million.
The ones that are not resistant, all right? And this one here, it's not like it's not like Superman, like from planet Krypton, all right? If you killed it enough with penicillin, it would probably die, all right? But it would take a lot more to actually kill it, all right? Maybe she didn't fill off her entire prescription here, right? So one is resistant to penicillin. Is she feeling better now?
No.
Yeah, oh, of course she's feeling better right now, because now instead of having millions of bacteria in her, she only has what? One. Oh, I'm fine, I feel really great right now, right? But what's going to happen? This one is going to then divide into
More.
2, into 4, into 8. And now 2 weeks later,
She said it.
2 weeks later, now we have 1 million resistant ones that are all now resistant to penicillin. If she coughs or spits or does something like this, what are the odds that she is going to be spreading the resistant one?
Very high.
100%.
Very high, because that's basically all she has inside of her now. All the non-resistant ones are going to be killed off. So far?
Yeah.
So this is what we mean when we say that antibiotics are a powerful agent of natural selection. Because we're killing off all the ones that are non-resistant, and the only ones that we're leaving are the ones that are resistant, who no longer have any competition. And this is why we're seeing the spread of antibiotic resistance. Not only are all these resistant, but will some of these have their own mutations? And so maybe one of theirs that also is resistant to penicillin might also be resistant to amoxicillin, or streptomycin, or something else. And that's how you develop these bacteria that have multiple resistance. So this is why doctors, way back in the 40s and the 50s, when they first developed penicillin, it's really that recent, all right, in the last century that they developed antibiotics. It was revolutionary. And it was revolutionary, but not in the way they necessarily thought, because they didn't understand how this process worked at the time here. They were putting antibiotics like penicillin in everything, because their idea back then, all bacteria bad. They're putting it in toothpaste. They're putting penicillin in toothpaste. It would taste like grass, all right? It would taste a little. They would put it in everything like this, with the idea that we'll kill as many things off as possible. But the more we treat them with antibiotics, the faster we're going to see what? Resistant ones spread. And this is why physicians now are not nearly as likely to prescribe antibiotics as casually as they used to. And when they do, it's with a course of antibiotics that are hopefully ensure that you hammer away at any ones that are starting to develop resistance. You take the full course of antibiotics that they give you. And as a healthcare provider, when you are prescribing it for your patients, you need to really let your patients know you need to finish off this entire course of antibiotics. Because so often, especially with populations that maybe don't have great health care or don't have a lot, they'll start feel better maybe after about 2 or 3 days, all right? And they start thinking to themselves, well, I'm feeling a lot better now. There's a couple left in here. Maybe let me just save these for the next time I get. Don't be shaking your head like nobody does that.
No, they do.
You know exactly what I'm talking about. It's like, let me just save these for the next time I get sick or my kid gets sick so I don't have to worry about running out to the hospital. They don't finish their course of antibiotics, and that's what's going to allow the resistant ones that might have just survived up till now to now take over. All right. Enough. That's my soapbox issue for the day here. All right. Instead of trying to start respiration right now, which would kind of be stupid since we only have a few minutes, I will give you the next few minutes off. You are welcome. But of course, we are going to be meeting in lab.